think also for higher constraint, I would go for this patient. Yeah. So what did you do, Sebastian? What does the audience do?
Yeah, so
70% did constraint, would recommend a constraint TKR. What did you do, Sebastian?
Yeah, so I agree with everything that was discussed. I used constraint, the constraint total knee. So just sort of these are the options. To the next slide with the post-op X-rays. So I used the constrained CCK Zimmer knee, and yes, in these patients, I think one of the issues with neurological patients is that with weakness, they sometimes hyperextend, and they need that hyperextension. So doing a hinge, you have to be careful in these types of patients because they may not be able to function with a hinge if they can't hyperextend and lock their knee. The other thing that I consider, which is something I've learned over time, is to minimize how much you release in these valgus knees on the lateral side. With the MCL being stretched out, you may want to consider, releasing laterally, but that will potentially increase the length of the leg. Plus, you're correcting the valgus, and that can result in a peroneal nerve palsy. So instead, what I do in these cases where the MCL is stretched out, I do a medial epicondyle osteotomy, and I advance the medial epicondyle with the MCL just to protect the implant against some of the forces that would potentially lead to loosening or wearing of the post. This is the patient at first follow-up in 6 weeks. So great result. That patient was very happy with it. And the one point, again, is that medial epicondyle osteotomy, which I rarely use, but has been very successful so far.
Very interesting case, Sebastian. Thank you very much for the presentation.